Good morning, my name is Rick Boddy. I'm a Professor of Emergency Medicine at the University of Manchester and a consultant at Manchester Royal Infirmary. It's a pleasure to join you today, and I'm going to be talking about practice-changing papers from 2021. So I've got two papers relating to COVID-19 at the start, and then we're going to move on to some non-COVID papers. We're going to start with a really important landmark trial. You probably know about the Recovery trial. It's the largest treatment trial, randomized controlled trial for COVID treatments in the world. It's included over 45,000 patients to date. And there are some really important findings. You may already be familiar with them, but let's break them down so that you can increase your understanding and know the rationale for why we give different treatments in patients who have COVID-19. So Recovery is what's called a platform trial. It has one protocol, and within that protocol, we include multiple different evaluations. So patients can be randomized to different arms of the trial. In general, they include hospitalized patients with confirmed or suspected COVID-19. For some of the different comparisons, the subgroups that are included are a bit more specific, as we'll see. And in general, the primary outcome of the trial is 28-day mortality. So let's look first of all at this really important comparison within the Recovery trial. Dexamethasone. So in the dexamethasone arm, this really hit the headlines. Over 2,000 patients were randomized to receive dexamethasone, and over 4,000 received usual care. Now, Recovery is still recruiting, but when there are enough patients recruited to one of the evaluations, they stop, analyse the data and rapidly report the data. These data were published in the New England Journal of Medicine last year. What we can see is that in the dexamethasone group, 22.9% of patients had died by 28 days, compared to 25.7% in the usual care group. So that gives you a rate ratio of 0.6. The confidence intervals here, you can see, don't cross 1. So this is a statistically significant difference. There is a mortality benefit with dexamethasone. The number needed to treat is just 50. Now compare that to tranexamic acid, for example, in major trauma. Tranexamic acid is a very, very beneficial, effective treatment for patients with major trauma. The number needed to treat was something like 70 or 80. 50 is a really small number needed to treat. It's a phenomenally effective treatment. The length of hospital stay was also shorter with dexamethasone, and there was a greater probability of being discharged alive. However, we can learn a bit more about this study when we start to look at the subgroups, and we start to understand then whether there are subgroups who might benefit from dexamethasone in particular. So in all participants, this chart on the left shows that dexamethasone led to survival benefits. You can see separation of the curves between dex and usual care, a rate ratio of 0.83, confidence intervals that don't cross 1, and a very significant p-value. When we look at the subgroup who were receiving invasive mechanical ventilation, you can see even greater difference between the curves. The rate ratio is 0.64. It's highly significant. Dexamethasone clearly efficacious for those patients. For patients who were receiving only oxygen, again you can see that dexamethasone is superior to usual care with a rate ratio of 0.82. Those confidence intervals don't cross 1, so it was beneficial. But then if we look at patients who weren't receiving any respiratory support, you can see no evidence of benefit with dexamethasone. In fact, dexamethasone is slightly worse than usual care, but it's clearly not statistically significant. So what this tells us is that dexamethasone is really effective for patients with COVID-19 in hospital who are receiving oxygen or a higher level of respiratory support, but not so effective if you're not requiring oxygen. The Recovery trial also reported the findings of tocilizumab last year. This was also reported in the New England Journal of Medicine. For this evaluation, they included a subgroup of patients with severe COVID-19. So tocilizumab is an IL-6 inhibitor, and this evaluation really was seeing whether we could further modulate the immune response in patients with severe COVID-19, which is perhaps a little hyperactive and causes many of the problems. So perhaps modulating that response might improve survival for patients. And the patients here had bilateral pneumonia, hypoxia, which there were well-defined parameters for that, and a confirmed diagnosis of COVID-19 on PCR. The primary outcome was a 7-category ordinal scale for clinical status at day 28. Now, at the bottom you can see the charts. On the left there's the improvement in clinical status, which is the primary outcome, and you can see in the tocilizumab arm there was significantly greater recovery than in the placebo arm. On the right you can see the percentage of patients discharged is also greater in the tocilizumab arm compared to the placebo arm. So here we've got evidence of benefit with tocilizumab in patients with severe COVID-19. The recovery trials have achieved an awful lot more as well. It's also shown that Regeneron, the monoclonal antibody cocktail, is effective for patients who are seronegative. It's also demonstrated that there are a number of treatments that are ineffective, have no evidence of benefit, including lopinavir, ritonavir, convalescent plasma, azithromycin, hydroxychloroquine, colchicine and aspirin. And there are a couple of ongoing evaluations. So this is on the whole really useful. And thinking about practice-changing papers and trials, this is certainly right up there from 2021. Next, let's move on to diagnostics. Now, I was involved with this, and I think I was very proud to be involved in this piece of work because it has changed how we behave, not just in emergency medicine, but as a society. So in August 2020, just after wave 1 of the pandemic, our government announced Operation Moonshot. As part of Operation Moonshot, there was an ambitious research agenda to evaluate new COVID tests. I was chief investigator for the Falcon study, I still am, and this is a platform study for diagnostics. We were asked to contribute to the Moonshot programme by evaluating the sensitivity of 4 lateral flow tests in the community. So we identified patients who tested positive for COVID in the community. We called them and asked for their consent. If they gave it, they came back to a drive-through testing centre. We took swabs from them. We ran the lateral flow tests on site, and we sent another one off to Public Health England, where a lab scientist also ran the test. And we ran PCR on those samples. We ran this at 15 testing centres across the UK. Here are pictures of some of the staff in Manchester in the top left running the tests. In Oxford at the top right, the testing centre in Birmingham's testing centre. This is a medical student. And then in the bottom right, you can see our sign directing people into the research bay. So here are our key findings from the Falcon study. And we evaluated the sensitivity, which is shown here in the purple bars in the chart. And the specificity was evaluated separately in a cohort of healthy people by a team in Oxford. The specificity was really good, around 99.7% for all of the lateral flow tests evaluated. Sensitivity, you can see, is not perfect. It's around 75%. Importantly, on the left, you can see a very interesting difference between the sensitivity of tests when run by healthcare workers and when run by lab scientists. The sensitivity was greater when lab scientists ran the tests. Now the swabs were done the same. This is just about running the tests, and you can see there is a difference in sensitivity. Now while that sensitivity is not perfect, this slide is really important because it shows how viral load affects the sensitivity. On the y-axis of these charts, we've got the proportion of patients who tested positive on the lateral flow test. Remember, all of these people in the study are positive for COVID. And on the x-axis, we've got the viral load increasing. And you can see that as your viral load increases, the sensitivity of the lateral flow tests increases rapidly, such that for patients with the highest viral load, CT value less than 18 on PCR, the sensitivity of the ANOVA test was 100% when lab workers ran the test, or 92% when run by healthcare workers. So the vast majority of patients with the high viral loads are being picked up. And that's important because they're the most infectious. So although we're only picking up 3/4 of infections, we're probably taking out the most infectious people. Now, what does that mean? Can you mix if you've got a negative lateral flow test? We rolled this out in the UK for asymptomatic individuals and mass population testing. So let's assume that we have a lateral flow test or rapid antigen test with 75% sensitivity and that 99.7% specificity. Assume the prevalence is like we have in the UK at the moment, 1.3 cases per million, and everybody's asymptomatic. So that's a big assumption. The probabilities here are probably overestimates because most people are symptomatic, of course. But on an individual level, if you test negative with your lateral flow test, there's a 0.6% chance you still have COVID. It's a pretty small chance. It's not ruled it out, but it's a small chance. And if you're positive, 87% chance. Now, that's really important, but on a population level, let's multiply that. Let's say 100 people want to meet under one roof. If they don't do any tests, there's a 13% chance that someone's going to have COVID in that room. And that's, going to lead to onward infections. But if all of the people who are going to that gathering do the tests, we can reduce that to 3%. And if repeated over and over again, you can see that that's going to reduce the spread of COVID-19. Moving on from COVID, let's talk about CPAP. So it's kind of relevant to COVID. We talked about whether we should be using helmets or hoods for CPAP instead of face masks because they may have less aerosol generating potential because you get lots of leak around the edges of the face mask and that could generate aerosols and spread COVID. So the helmets have some theoretical advantages. I'm going to cover here a randomized controlled trial which included patients with acute respiratory failure who either had cardiogenic pulmonary edema or acute exacerbations of COPD. They were randomized to CPAP by helmet or by face mask. The primary outcome of the trial was a reduction in respiratory rate, which of course is a surrogate outcome for improvements in outcome more generally, but we can see here that in this trial there was a significantly greater reduction in respiratory rate in the helmet group than there was in the face mask group. There was also a significantly greater reduction in heart rate. The face mask group had a bigger improvement in PO2, but there was also more discomfort with face masks, and the intubation rate was greater in the face mask group. So, although that primary outcome, respiratory rate reduction, is arguably less clinically meaningful than something like mortality, on a whole, here you can see convincing data to suggest that helmet CPAP seems to be better than face masks. Moving on to acute coronary syndromes, we saw the publication of a landmark trial, Rapid CTCA, in the British Medical Journal. It was run by a colleague of mine, Alistair Gray, in Edinburgh. And they looked at the use of CT coronary angiography for patients with what they said was intermediate risk acute coronary syndrome. Now, I would possibly argue that this is quite a high-risk group. It was a randomized controlled trial. Patients were included if they had a provisional diagnosis of acute coronary syndrome, but they also had to have either known coronary artery disease, elevated troponin, or an abnormal ECG. I think that's relatively high risk. And they were randomized either to CTCA or standard care. The primary outcome was death or MI at 1 year. And here are the key findings from the Rapid CTCA trial. So, of over 1,700 patients, you can see a very, very small actual difference between the incidence of the primary outcome between CTCA and standard care, and it wasn't statistically significant. So at the bottom you see the adjusted hazard ratio, but the confidence intervals clearly cross 1, p-value is 0.65, there's no evidence of significant benefit with CTCA. The secondary analyses were also quite interesting. So at the top you can see use of coronary angiography between the groups. What you can see here is that patients who were in the CTCA group were significantly less likely to receive invasive angiography, but there was no difference in the rate of coronary intervention between the two groups. Now you could interpret that one of two ways, couldn't you? You could say, well, actually, there's no difference in the incidence of the primary outcome, so CTCA doesn't seem to be adding any value. But at the same time, you could also say, well, it was no worse, and fewer patients had to undergo a minor surgical procedure, invasive coronary angiography, so there potentially is some benefit. Also, this was a relatively high-risk group of patients included, and potentially you could use, we use it in Manchester, CTCA, just to expedite inpatient investigations. But in this trial, no evidence of clinical benefit. The patients don't do any better with CTCA. Lastly, let's move on to antibiotics for appendicitis. So patients with appendicitis will, of course, traditionally go for surgery. It's a standard of care that they should have appendicectomy. But in this trial, published in the New England Journal of Medicine, the authors had a look at whether antibiotics are as good as surgery for patients with appendicitis. So they included adults with confirmed appendicitis. You might think that they would have included a low-risk population. In fact, the only key exclusions here were diffuse peritonitis or septic shock. The primary outcome was EQ5D at 30 days, and the trial was a non-inferiority trial. So that means they were seeking to show that antibiotics were no worse than surgery for appendicitis, and that's really important, as we'll come back to later. Now, just to touch on that primary outcome, EQ5D, this is a measure of quality of life. It's not disease specific, it just measures your function, your quality of life overall. In this trial, patients were randomised to either intravenous antibiotics for at least 24 hours and then 10 days of oral antibiotics, or appendectomy, which could be laparoscopic or open at the discretion of the surgeon. Now, before we look at the results, let's just have a look at the principle behind non-inferiority trials. Let's imagine we're plotting the results, and we have a line of no effect here. So if the two treatments are equally efficacious, our result is going to be plotted right on that line. If antibiotics are better, we'll plot it to the left. If surgery is better, we'll plot it to the right. Now, what's really crucial to understand in a non-inferiority trial is that there's a non-inferiority margin. So this is the minimum clinically significant difference. So what we're saying is antibiotics could be a bit worse, but actually that's not clinically significant. It wouldn't make a difference in the long run to the patients if it was only that much worse. And that's a non-inferiority margin. So when we report a non-inferiority trial, we could report them in a number of ways. So let's imagine these pink lines are confidence intervals. And you can see at the top, this first one at the top here, the confidence intervals go from being much better than surgery to a bit worse, but not worse than the non-inferiority margin. That's non-inferior. Or we could find that the treatment actually is, the lower confidence intervals still a bit worse than surgery, but the upper bound doesn't cross the non-inferiority margin. That's still non-inferior. Further down, we've got the superior trial. So here, the confidence intervals don't cross the line of no effect. That would mean that antibiotics are superior to surgery. Or at the bottom, we fail to show non-inferiority because the confidence intervals cross that non-inferiority margin. Now in this trial, the authors found that antibiotics were ever so slightly better, where that circle is. The confidence intervals crossed the line of effect, so we can't say that it's significantly better than surgery, but it didn't cross the non-inferiority margin. This graph is not to scale, but you can see the results at the bottom here. There was the difference, the confidence intervals didn't cross 0.05, which was the non-inferiority margin, so we can conclude that antibiotics were non-inferior to surgery. The authors also looked at secondary outcomes. There was no difference in symptom resolution at a week, 2 weeks, or 30 days. There was more frequent use of ED or urgent care in the antibiotic group, 9% versus 4%, but there were fewer missed work days in the antibiotic group. Now, 30% of the antibiotic group did get surgery within 90 days, but although you could say, well, that's not great, 70% didn't get surgery, and that would have been our previous standard of care. So think of it that way. And delaying the surgery didn't translate into greater missed work days, for example, or lower EQ5D when measured. So definitive evidence, really, or convincing evidence that antibiotics could be used as an alternative to surgery in appendicitis. So we've covered a number of things here. In COVID-19, I've shown you the evidence for dexamethasone and tocilizumab being effective for subgroups of patients on oxygen for dexamethasone in hospital, or for the severe COVID-19 pneumonia for tocilizumab. A number of treatments aren't effective. They include aspirin, colchicine, hydroxychloroquine, lopinavir, ritonavir. And we've shown that lateral flow tests have imperfect sensitivity, very high specificity, but despite their imperfect sensitivity, they could be used on a population level to limit spread when used for mass population testing. And in non-COVID emergency medicine, antibiotics could be used to avoid surgery for appendicitis. CTCA showed no evidence of benefit in the rapid CTCA trial. But was it really an intermediate risk group of patients? The jury's still out, perhaps on that one, but at the moment, no clear mortality benefit for our patients. And Helmet CPAP now has some convincing data from an RCT to suggest that it has some advantages over face mask CPAP. I hope that's been valuable. Thank you very much indeed. It's been an honour to talk at SASM this year. Thank you. Bye.